Welcome to the RCOT Insights session, Want to Know More About Occupational Therapy in Primary Care. My name is Genevieve Smyth and I'm a Professional Advisor at RCOT. This session will be a panel discussion with therapists who work in the area and will help answer some of the common questions we get frequently asked. So to give you some context before we start, Wales and Scotland have led the way with early pilots of occupational therapy in primary care, and these are now being expanded and built on. In Northern Ireland and in England, the services are generally at an earlier stage, but with 10,000 new AHP roles expected in primary care by 2024, this is rapidly changing. So really exciting times. So to our panel then, I'm going to ask you to introduce yourself, where you work, and to answer this first question, which is how did you move into primary care? Kosiwa, would you like to start?
Hello, my name's Kosiwa Lakosu and I'm a mental health occupational therapist working in Winchester Primary Care Network. I started this role in January 2021 and prior to working in the PCN, I was working in an integrated care team for 2 years when I decided that I really fancied a change and I wanted to challenge myself a bit more in my career and be more of an autonomous practitioner. So I applied for the role and was successful and haven't really turned back. It's been a fantastic experience. I've been able to set up, our own service and I'm really enjoying the time that I'm spending there so far.
Fantastic, thank you.
Hello, my name's Helen Blomfield. I'm an occupational therapist in Sheffield and I moved into primary care in February. I was the second OT to move into primary care, and we're taking an interesting approach in Sheffield where the 3 OTs are looking at different projects. So my focus is looking at working with nursing homes and residential homes. My colleague Julia Clifford is looking at a frailty project with people in their own home, and Laura De Bono is looking at working with people with mental health and long-term conditions. So I was really excited to move into primary care. I've worked for 26 years now in lots of different settings, in physical, community rehab teams, dementia services. And I was frustrated, I suppose, at the top of band 6 and realising that I didn't really want to be an operational manager. I wanted to stay a clinician. So I learnt a lot about these new posts when I took a fellowship role with Health Education England on their Future Leaders programme and learnt more about these exciting new roles. So when the jobs started coming up, I leapt and was lucky enough to get one of the jobs.
Great, fantastic. Thank you, Helen. Thanks.
Hi, my name's Chantal Martin. I'm an occupational therapist working in a primary care network in West Sussex. My route into primary care has been a little bit different. I chose to take a role as a social prescriber for the past year, and then in February successfully pitched to become the PCN occupational therapist, working strongly with the social prescriber who's newly been recruited.
Fantastic, thank you.
Hi everyone, my name is Emma Finnegan. I am an occupational therapist working as a senior mental health practitioner in primary care practice in Northern Ireland. There has been a new regional rollout of the model for multidisciplinary teams in primary care in Northern Ireland. And as an OT, I thought the mental health practitioner role would be a great exciting adventure and an opportunity for new project rollout and new ways of working within GP practice. I've always been excited about new ventures within mental health, and my experience as an OT so far has always been with new teams and new project development. So this was something that I was really excited to move into. And I've moved into the role in January 2020. So it has been interesting so far and really, really clear that there is such a demand for our skills as OTs so far. So I'm looking forward to discussing that moving forward.
Perfect. Thank you so much. And I love the fact that all of you are innovators and you've all been driven to search and try something new. And you've got that recognition that there is so much that we can do in this area. So thank you so much. Okay, so on to our second question then for the panel. And this is probably our second most frequently asked question after how do you move into primary care is what do you do in primary care, including the types of patients you see and the occupational therapy skills you use?
So within my team, I form a wider primary care mental health team. It's a bit of a mouthful. And there's actually two of us, two occupational therapists within the team. So there's myself, who works 4 days a week, and my colleague is also a CBT practitioner. And she works in her OT role 2 days a week. So we also have mental health practitioners, a counsellor, social prescribers. Oh, what else have we got? We've got a big team, and I think that's everyone. But yeah, so our role is predominantly around mental health, but because, as we all know, we're dual trained as occupational therapists, so I actually see quite a lot of physical health patients as well, and I'm able to bring my skills from my previous experience. I have worked with a lot of chronic pain patients, a lot of neurological disorders, obviously a lot of anxiety, depression, some schizophrenia, and each day is completely different. That's why I love the role. I think we can just bring all of our skills and really support the patients that are sometimes too unwell for particular services, but not unwell enough for other services. And I think we fill the gap really well.
Perfect. Thank you so much. That's a lovely description of what happens in primary care, that sometimes people they're sort of almost not quite unwell enough to get to secondary care, but they need much more than they're getting currently in primary care. And that lovely description of our ability to work across different types of conditions. So thank you ever so much.
So I work with 8 care homes, nursing and residential, and they're covered by 5 different GP practices. So I actually receive my referrals from the care teams and the managers in the home. I'm tending not to see the same type of patients that the doctors see, because they're actually quite poorly. A lot of them are kind of end of life and have got sort of multiple problems. So it tends to be that the carers in the home are referring, and they refer just via email to me. So a lot of the work I'm doing is looking at falls prevention. It's looking at moving and handling. Have they got the right equipment? Are they managing to get out of bed? Looking at quality of life. So with every person that I see, and I'd like to see all the new admissions to the home, I do a very comprehensive holistic assessment. And I think what I'm finding interesting is that although they refer for one thing, as an OT, I'm picking up so many other areas that I can get involved in. So I'm looking at specialist seating, I'm looking at real quality of life, behavioural problems some of the units are having, and what are triggering those behaviours in people. So some of the units have got EMI units, and I'm going to be starting a project looking at their real quality of life, because we've got quite a few people during COVID that haven't had many visitors and lacked stimulation. So we're looking at trying to get them outdoors. So that's a new project that I'm working on. And I think I will say that it's really exciting to be in primary care, because you could be quite creative about the projects you work with and who you join up to work with. So I am working very closely with social prescribers, but we're also looking at putting OT students into a very large assisted living building, private building, and I'm going to be giving them long arm supervision, but they're going to be supervised in-house in that unit. So it's one of those emerging placements roles. So that's quite exciting as well.
Excellent. And I love that idea about obviously thinking about our brand new and our training occupational therapists and exposing them to the breadth and diversity of the role that we can have in primary care. So lovely. Thank you. Thank you, Helen.
Yeah, I think I want to echo the range, the spread, the potential, the opportunity, which is really exciting to me. I mean, I'm in a transition point from setting up and keeping a social prescribing service going, and also having looked at where the gaps from our local services are in healthcare, to where I can fill some of these gaps occupationally with people, and enhance the complexity of that social prescriber role. So some of the health inequalities, the social determinants of health, the fun stuff is connecting people up, not just to health and social care services, but community services as well, and those connections and partnerships that I've made. So yes, I see a wide range of conditions, from sort of long COVID, the mental health, sometimes the frailty, which in my area, we have quite a lot of provision for that, but actually supporting some of the staff in how to access the right services for the person at the right time. And then actually doing some of the doing, just with people who may be a little bit confused or swamped with perhaps different stresses in their world, and how we can unpick that using some occupational assessments, and how to plan what matters to them and focus on them. And that's been the novelty, to work with people the way I want to work with them.
How lovely. I feel like rushing out now to apply for a job. It just that, you know, all of you describing it, you know, that really, you know, articulating really beautifully that actually this is the gift that we can bring, and there's so much that we can do. And that really nice, I think, Chantal, what I was really hearing there is that cross-boundary working that we can do, and the creativity that we can bring to this area of practice. So thank you for that.
I suppose in Northern Ireland, the teams are structured a little differently at the moment with the regional rollout. So within the current teams, we have a mental health practitioner, a social worker, a physio, and we have pharmacy as well. And even though this is a generic role, it's my first experience of a generic role in terms of my OT career so far. What we do is we have a balance between clinic contact, and then we also have templated protected time for service development and new projects for health promotion and early intervention initiatives within the community. So, I mean, and as occupational therapists, that's something, community wellness, resilience, citizenship within the community, that's something that really strongly sits with us as an occupation. So I think there is a wealth of opportunities for service development in this role moving forward. In the clinics, what we mainly do then is provide first contact for patients who have maybe an undiagnosed mental health issue. Then that could be, interestingly, across a lifespan referrals. So basically anyone who's registered with the practice is eligible for mental health support. And I suppose since my induction, it has been clear that there's, as echoed by the panel here, there's been so many different variety of presentations, and so many new learning opportunities as a result of the variety of conditions that have been presenting. By far, anxiety, depression, has been most common. However, there's other presentations such as gender dysphoria. There's been the occupational job loss that has been resulted as through the pandemic has been really caused a huge shift in mental health services and the amount of presentations that we are seeing. And I think there's a great role here in terms of being a bridge between ourselves, GP practices, and the community, and creating more community resilience and resources and the use of what is out there. And especially there's been such a focus on that with the pandemic. It'd be really good. But even though this is quite a generic role, I have to say, in every presentation, you are always using a holistic treatment approach. We have fantastic frames of reference here. We're constantly looking at volition, habituation, roles, personal identity. And I mean, as occupational therapists, really, that is a fantastic area to start treatment with. So we focus on short-term brief interventions, and it can vary from one-to-one and pursuing into group work, hopefully in the future. So as OTs, I mean, our skills are being very much utilised, and I think it's a very exciting area in Northern Ireland for development.
And thank you so much for just, you made so many crucial points. All of you are making so many crucial points, but certainly you have made actually what is a really, really crucial one, because all of my career was in secondary care. So by the time I saw someone, usually their diagnosis was very clear, but actually that can be very different in primary care, especially if it's the first time they've turned up and actually they have an undifferentiated diagnosis. What that means is we don't know yet what the problem is. So being able to bring our occupational therapy skills and thinking to that, I think is great. I love the idea that you're getting protected time for these development projects as well, because it could be so easy to get sucked into, because there are so many people we could be seeing, but actually having some time to step back and review and think, actually, where can I best bring my expertise in this system, and where might we be in 6 months or a year's time is absolutely fantastic. So thank you for that, Emma, as well, bringing that into the room, as I say. Okay, on to our third question. Now, this really is another very, very common question, and it's about what outcome measures do you use? And if you have any other comments about this subject of how we demonstrate value and impact, I'm sure our audience would love to know more. So over to you.
So within my service, we've been using the Canadian Occupational Performance Measure, so the COPM, as most people know it. And as I said, I'm working with another occupational therapist, and this is an outcome measure that we both thought would fit in with the service quite well. And based on when I've used it in previous services, so I really like the fact that it covers a lot of different domains of the individual's life, self-care, leisure, but really breaks it down into the different components of all those areas. And then we go through all of that and we ask them, well, what are you doing and what are you finding difficult, and then rating it out of the importance. So then it's really person-centered to help identify what are the areas that the patient wants to work on, because as we all know as therapists, our idea of what's really important can be completely different to what the idea of what the patient feels is very important. So we use that to help structure and frame our initial assessment. We also use some risk outcome measures to help identify, how high risk is a patient when it comes to things like deliberate self-harm or suicidal ideation or, lack of motivation. So we use the PHQ-9 and the GAD-7, and that's again working with the patient and discussing, okay, well, what can we put into place to help manage those risky behaviours? We want to make it into a therapeutic conversation rather than just a tick box exercise. And we thought that was really important, because we've all seen different standardized assessments that haven't been used very well in care, and that can have a real detrimental effect on the patient. But similar to what you said, Jen, it's so important that we actually put aside the time to focus and to develop the service. And I think that's what we've all done, because going into somewhere and developing a new service is actually really difficult, and you need to allow yourself the time to say, okay, let me just focus on what I want to do. Where do I want to be in 6 months, as you say? What's working well? What isn't working well? What can I change? And I think we need to allow ourselves to utilize that time. Because I know I'll be the first one to admit that I always want to be go, 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 and I want to, support as many patients as I can. But we need to make sure we're doing it effectively.
Absolutely, and thank you for articulating that. And I think that's a really crucial point about with brand new roles. It's even more important that we think about how are we going to show our value and our impact. And I love the fact that you're using occupational therapy measures. COPM is a great tool as well, because it brings that personalized aspect, and people can rate themselves. They can rate themselves before and after and during the intervention. Actually, you're mixing it really nicely with recognized standardized mental health assessments that help deal with risk assessment, because as I was talking about, primary care very different from secondary care. You get people turning up, you don't know what the problems are, and the risk assessment is in a very different context, because they're not held in a wider secondary care team. So risk is really, really crucial. So thank you for reminding us of that. Really crucial. Thank you.
Okay, I'm going to be really honest here and say that I haven't actually found an outcome measure that suits the people that I'm working with. I think I'd like to have sort of a patient satisfaction questionnaire, but a lot of the people I'm working with have communication problems and are sort of later stages of dementia. Because of COVID, we're not really having the families coming in, so you're not really working with the families. They've got very limited visiting hours still. So I'm struggling, but what I have done is I have designed a very comprehensive holistic assessment, and what I'm doing is I'm making sure that that's scanned into the notes of the home, and it's very clearly listing all the recommendations and the reason why I'm recommending, and then the actions that I'm going to be taking, and then I'm obviously typing that up on the computer system for the GPs to see as well. My colleagues are using them. So Julia in Frailty is using the goal attainment scale, and Laura, who's got the mental health focus, is using the occupational self-assessment, the short form. But yes, I'm open to any suggestions, so get in touch if you have any.
Fantastic. And I think, thank you for that honest answer. Outcome measures have to be meaningful and they have to make sense. And certainly you won't be the only person who's on a journey of finding what is the right way of doing this. So thank you for that.
Yeah, I will just add that we're looking to gain funds to do a really comprehensive evaluation, a research project, and that there's a big team led by the OT academic, Nat Jones. So there are going to be lots of interviews with GPs and ourselves and the managers from the home. So hopefully, we'll get some great results from that, and it will be published.
Right, and actually that is really important because getting those patient level outcome measures is crucial, and finding out what families and carers mean, but actually bringing research methodology in a more robust way and in a larger way to systems is an excellent and much larger way of demonstrating impact. And then you get the right level data that could be published in the literature and then shared and built on. So it's great. So good luck. I hope you get the funding for that as well. Really, really exciting.
And thank you, Helen, for that honesty first, because I'm on a similar journey and transition. I'm not sure I've got the one size fits all that I'm looking for. I don't know potentially if it's there and relevant to everybody on all sorts of different scales that I work on, from sort of a 5-10 minute conversation to a 2-hour conversation or a chunk of work. So the most meaningful ones for me have actually been the patient feedback directly to myself at the end of the phone call. And I really try and capture that in our data spreadsheets to remind me of that patient's perception of the work that we've done together. And that's kind of holding out as more important. But as I'm transitioning from the social prescribing world, where the focus has kind of been on the ONS4 or potentially the WEMWeb's short version, I've got that freedom again, which is lovely to kind of explore. So I've started bringing in occupational formulations into my clinical notes, which I know is not an outcome measure as such, but to show the value of occupational theory, I guess, behind the work that I'm doing. And then also started to use the OSHA, the short version, if it's appropriate with people. I've used the wellbeing stars with some people as well. So for me, I'm still on that journey, open to suggestions like Helen, and I know that it will have to come, and I want to show the value of what I'm doing. But the most powerful thing has been that patient feedback so far.
Yeah, excellent. Thank you. And those stories are worth their weight in gold, aren't they, when you get a really great case study that shows our value. So thank you for that.
Within our role in Northern Ireland, we are using the PHQ and the GAD-7, much like was mentioned earlier. And I suppose because within the mental health practitioner role, we also have social workers and we have mental health nurses also within this type of role. I'm hopeful that there has been also, as the roles continue to develop and we have more health initiatives and projects launched, such as our group work and our web development and safety planning projects, that we can avail of more outcome measures and tools to capture that really important feedback, because this is such a new area for us in mental health in Northern Ireland. And we also have completed 2 pilots, so surveys recently, to capture that qualitative and quantitative feedback on the patient experience so far. So that's all to be. A little bit of feedback is needed on that just yet. So it's early days, but we are getting there and things are moving. So
great. And the Department of Health in Northern Ireland also has a long-term evaluation across the whole of Northern Ireland of these new roles in primary care. So there is some national work going on that will report. I think we won't report for a while, but we will get some really nice high-level data out of your services as well. So great. Okay, so on to our final question then. I can't believe we're on to our final question. Feels like there's so much more we could be talking about, but on to our final question then, which is, how do you work with GPs and the rest of the primary care team?
So for me, I think it's definitely relationships that you've got to work on and build on, like in any service. I find MDT working, multidisciplinary teams, so important. I just feel like we can learn so much from each other. We have an MDT meeting once a week, and I think they're fantastic. We have the GPs attending, we have our local homelessness charity, our local addiction charity, our CMHT, and we'd be lost without each other, honestly. But I guess GP specifically, so our referrals all come from our primary care mental health team. So they come from our health and wellbeing coaches, and the GPs referring to them. But of course, we're holding the GP's patients. So we tend to use something called tasks on EMIS to liaise directly with GPs. But also if I'm in the surgery, I'll just be like, Doctor so-and-so, can I just, grab you to speak about a patient? And that helps them to recognise, actually, oh, that's the occupational therapist, because we're all so new, aren't we? They see our pictures, but actually we don't really know who we are. And then it allows you to explain your role in a bit more detail, especially as OT is so varied. So I do feel it gets better. I feel like with anything, with time, it will improve. There are challenges, but there always will be, no matter what service you work in. So it's about, having some knockbacks, but then being able to come back from that and think, okay, constructively, well, what do I need to do differently? So I've been having those discussions with my team and with my supervisor to try and move forward the best way possible.
Perfect. Thank you. And thank you for talking about the different ways that we build those relationships and the reality that it's relationships, and sometimes things work and sometimes things don't work. But the crucial thing is, as you've said, it's that learning and thinking about, okay, well, for whatever reason that didn't work, let's rethink this and work out another way of doing it. So thanks for that. Really good.
Yeah, I completely agree with everything you've said. I think it is about building those relationships. I think it's about working out when the GPs are actually having their lunch break and making sure that maybe you time yours at the same time, so you can promote what you're doing and educate them a little bit on the OT role. Finding a space is a challenge. So in Sheffield, we're all working across a number of different GP practices. So it is difficult because what you realise is when you go into GP practices that space is a premium, and it's really difficult to find an office. We have just now found a base in Sheffield. It's taken a while. Unfortunately, it's not in a GP practice, so it's separate to the GPs, which is a shame, because I think it's easier to embed yourself if you're actually based with them. But what we are working as more of a team with the social prescribers, the care coordinator, the mental health nurse, the paramedics. So we're all sort of going to be working in the same space, and I'm supervising a couple of the social prescribers, which has been great, giving them that support. So I think, yeah, it is about forming teams, having that multidisciplinary working. With regards to the GPs, I do tend to get my referrals directly from the nursing homes, but I do actually then go back to them and through their system one, task them to ask them questions. So that's quite a useful way. Yeah. Perfect.
Thank you.
Yeah, I think the biggest realization was actually it's quite hard coming into it. It's quite hard across different practices to be a presence when the practices are under so many demands at the moment as well. I mean, COVID the past year really didn't help of being more distant from everybody or behind closed doors. So yeah, it's that creativity again that comes into it. No one way works. The informal bit seems to be brilliant. Can you capture something in your notes to show the different conversations that you're having with their patients the next time they read them? Can you send a newsletter out? I think I've tried it every different way possible, and we're now doing sort of little pop-up messages that we're in the building today, come and see us, have a chat. And just always sort of thinking, is there something else I can do that really enhances those relationships? It's not easy, it takes much longer than expected, but you keep going with it and it's worth it. And when it comes together, it's magic. And there obviously are some meetings, and I hope that they will grow, where, like Kosovo, we can actually have some meaningful MDT discussions. I think we're very, in my world, we're very stuck in sort of task-based working or looking for solution-based working. And it'd be lovely for that to evolve over the next couple of years. I think it'll take time into something that can bring everybody together.
Perfect. Thanks, Chantal. And Emma, I'm just aware of time, actually. We're really almost at the end. Emma, have you got any brief things you want to say to add to that?
Just to echo what everyone has said already, it has been challenging during the pandemic, but as OTs, we are super creative and we will push this forward. The GPs have been incredibly supportive. It is nabbing someone on the day, even over the kettle if you can, and having those case discussions. The GPs have been great in having multidisciplinary teams to embed all the teams in the practices, so we have those opportunities for case discussion, and that has been incredible and something that will grow as the team does.
Perfect. Thank you so much. So we have come to the end of our insight session now. There's so much more to be said on the subject. So if you'd like to continue the conversation with us, please go to the RCOT website, look at the primary care topics page, and you'll find monthly drop-in sessions and an email network. In addition, in autumn, it will see the release of the Advanced Practice Occupational Therapy Credential Framework in Primary Care and a roadmap for how occupational therapists can develop from first contact practitioner models to being a full advanced practice occupational therapist. So some really great CPD opportunities and guidance coming out. Please look out for that. So finally, a very, very big thank you to Kosovo, to Emma, to Chantal and to Helen for being our panelists. And we look forward to seeing you all again soon. Goodbye.